much of what you're going to do if you need to do a completion thyroidectomy. So these are my two little comments on a very good video. Jay, congratulations.
Thank you very much. That's kind word. Yes, your panel members are here. I think you can ready to start, I think.
Yep. So shall I just share my screen? Is that right?
Yeah, please. Yeah.
So okay, so thanks, Jay, again for your very kind invitation. I'm just going to briefly introduce my panel. I think Professor De Cruz is not on, but I think the rest of the panel is in. So we got, just as a note of what was in the panel. So Neil Sharma, who is a head and neck consultant in Birmingham, and is again one of the kind of the new guns on thyroid surgery, the same as Enyi, who was one of our fellows, and he went to Australia to do robotic surgery, and now is back in St George's as a consultant head and neck surgeon. Ian, who doesn't need any introduction, especially in Scotland. He was one of our fellows as well. He was our first interface fellow, and then he went to the Memorial to do a clinical fellowship. So and he came back and he's now a consultant in Edinburgh, and he's got a fantastic track record in publishing in thyroid cancer. And then we got Riffat, who he came to England to do his training, whereas everybody kind of went to Australia. He came to England to do his fellowship in Cambridge, and he's now a consultant in Sydney. And it's great to have you here. I know this is about 11 o'clock, isn't it? I think apparently the pubs is already closed in Sydney, so you can join us. That's really good. And then last but not least, we have Professor Professor Nicholas Reid, who is a very prominent clinical oncologist in Glasgow, at the University of Glasgow, and he's going to provide the non-surgical aspects of this panel. So I was asked to moderate the panel on advanced differentiated thyroid cancer, and also to introduce some aspects of the non-surgical treatment, although I think later on, Kate Neilball will enlighten us about the new advances on non-surgical treatments. So from my point of view, I have no disclosures. I have all those patients that are presented here. They consented to have their photographs used in roundtables, and it's nice that these patients they do that. So the first case is this gentleman you see here is 64-year-old driver, increasing history of shortness of breath. He went to the GP. He had a chest X-ray, which basically showed a large mediastinal shadow. He had an ultrasound guided FNA, which showed a U4 Thy3F Bethesda 4 for those who are not UK based. And that centrally that was upgraded to a Bethesda 5. So here, what I would probably like to ask the panel, and perhaps we can start with Neil, is that if you do have this sort of kind of patient in clinic, what sort of kind of other investigations would you do if you do have that degree of suspicion of malignancy?
Thanks, Ricard. So yeah, everything that you put in front of us is worrying: his age, his gender, the upgrading up to Thy4 Bethesda 5, his shortness of breath, and this upper mediastinal shadow. So good medical history. I'm thinking, what's going to be problems if I'm operating on him? What's his comorbidities? What's his medication? And obviously his family history. Nasendoscopy, what are his vocal cords doing? And how is he looking at rest? What's his exercise tolerance? And then if we're sending him off, he's had an ultrasound already, I'd want to be getting a CT, and we do in Birmingham CT neck and chest. We don't routinely MRI neck, so I'd be wanting to cross-section imaging to have a look, and that's going to give me an idea as to what his upper mediastinum's like, as well as staging his chest. I'd hope from the ultrasound I'd know what his lateral compartments of his neck are like in terms of lymphatic spread.
Yeah, that's great.
And I'd also get some bloods on him as well. I'd want to know what his thyroid function is and his antibody status.
Absolutely. Okay, so they were all normal. Thyroid function tests were normal. Thyroid antibodies were normal. And then obviously now we come to the cross-sectional imaging, which obviously caused some degree of debate. We're talking about suspected thyroid cancer, and then what I would like to kind of have a panel agree is that is the contrast, not contrast issue, because obviously I personally feel that we should obviously have all these patients with contrast. I think obviously by the time that the contrast is kind of washed out, or by the time you kind of do the operation and the patient may potentially need radioiodine, will be probably about 6 weeks to 2 months, and then therefore somebody with a reasonable renal function, that contrast will not potentially kind of stun any kind of radioiodine. But I just wanted to have an agreement from everybody. We're going to perhaps start with Farouk in Australia. Would you guys have a problem with kind of indicating? Well, first of all, would you be doing or asking for contrast on these scans in thyroid cancer setting, or you not? And then how do you go about?
Yeah, I think I reiterate what Neil just said. I mean, the sequence of investigations, endoscopy, cross-sectional CT, definitely with contrast for us, because there are two main things here. One's the issue of malignancy. The other is the issue of compression, with a history of shortness of breath, the assessment of the tracheal compression, the extent and the depth into the mediastinum, whether it's mainly in the anterior mediastinum or in the posterior mediastinum. We published on this about CT factors that may or may not predicate a need for an assistive sternotomy or manubriotomy. So these factors, you don't want to go in with any surprises in the operating theater. So you want to be well prepared. You've got one good shot at it, and a CT scan with contrast definitely for us. And I agree, in our system, by the time you operate, these patients are at least 2 months away from their radioactive iodine, so it's well and truly washed out.
That's great. Enyi and Ian, do you have a view on this?
Right, Ricard, I agree with Farouk and Neil. Same thing. CT with contrast, no debate.
Ian, I've heard about the financial restrictions of not doing any or not using any energy devices in Scotland. Do you have a kind of a problem by giving contrast? Is it too expensive to get contrast, or what you guys do? That's why the NHS in England is so smashed, because we're using all these energy devices in the expensive places. So, but anyway, contrast or not contrast in Scotland?
No, Scotland's the land of milk, honey, and iodine, and we could use as much as we want. But I don't think it's a realistic risk that you stun thyrocytes. And given the nature of this talk, we're probably looking at malignancy. And it's going to be absolutely essential to know the relationship between the mediastinal vessels, the airway, and the tumor. And that's far more important than any theoretical, down regulation of RAI, which we heard earlier doesn't do much anyway. So the key is going to be a complete surgical resection in this case, I suspect. And anything you can do.
I ask?
Because mediastinal MR isn't very good because of the breath artifact.
I agree. I mean, I think we do have a consensus here, and I think everybody's really nailed the the question from my point of view. Professor Reid, you are going to give radioiodine to these patients. Are you concerned about the contrast of these patients? If I can ask a non-surgical opinion on this.
No, I don't think so. I mean, I think that the quality of added information you get from using contrast must outweigh any harm, as it were, from not using contrast. So I think it's a no-brainer. And as you've already said, that the time scale, if we're not likely to be giving radioiodine for 8 to 12 weeks after the sort of the time the contrast scan is done. So I don't think it's an issue. I have no problem.
That's great.
And
that's brilliant.
We can equally afford to do it.
Yeah. Thank you. Thanks. I think we have a consensus on that. That's basically what the patient had. So we got two representative images of this very unpleasant mass. It goes down beyond the aortic arch. It's got a kind of a funny shape. basically pushing part of the lung in. And the question is now, in terms of kind of surgical planning, guys, are you going to have a you know that this potentially suspected cancer? Are you guys going to have somebody to help you out, or do you think that this patient will need an stenotomy or a mini stenotomy or a partial stenotomy? If we can start perhaps with Neil.
So looking at this scan, we've got this deep right-sided retrosternal extension, and again, as Ian said, the nature of the talk, we're looking at cancer most likely. So what am I concerned about here? Well, the shape of the thyroid itself, it's sort of bowling skittle shape, so it's narrow at the bottom. So that's a positive for me towards it. But that tracheal compression, or I'm assuming it's compression, is a concern. You know, when you've got a benign goiter, we know that we can get an ET tube down that'll push that aside. But when you've got malignant goiters in the mediastinum compressing the trachea, they're not always expandable. So they need a good anaesthetic workup. I mean, this is why you're short of breath, isn't it? Because putting an ET tube down there could be challenging, and you have to be prepared for that and aware of that. When it's down to this level, it's not a one rule for everything. For me, I think for malignant cases, I would have my thoracic surgeons, and I'd probably have in this case, seeing as we're dealing with a likely malignancy, I'd want them on hand. I think the need for a stenotomy for him is high. That inferior edge looks quite fluffy on the left-hand picture. I don't know how much it's going to be stuck down to the vessels, and the last thing I want is to have a big bleed that's uncontrolled. So yeah, I think, and that right-hand picture, that edge of the trachea, that's looking again a little worrying for me in terms of potential invasion. So perhaps even a fibre optic bronchoscopy before we go down the line of anaesthetic to see if there's any intraluminal disease, because that would significantly affect things if there was at that level.
Yeah, that's good. I mean, I guess all the panel have got they work in academic tertiary institutions, and we all have access to thoracic surgeons. But I mean, we do have obviously this debate in perhaps not so much in our center, but in other centers about basically some ENT or head and neck surgeons doing their own stenotomies or partial stenotomies. Any of you guys do your own stenotomies? Farouk, perhaps?
No, we've got an excellent thoracic unit. And again, I agree with Neil. I think the shape of this goiter, the likelihood that it's a cancer, it extends to the posterior mediastinum on the axial scans. And most of the goiter is actually below the level of the first rib. So if this is completely benign and you're doing it for aerodigestive compressive symptoms, look, you can divide the isthmus, mobilize all around, put Ratex and try and deliver it, and it probably will come out. The issue is a lot of times you get subtle capsular ruptures when you do that. And we've all seen it. You get bits of thyroid that basically come out of the capsule. Now, if that's a PAP-CA or an aggressive variant of PAP-CA, then you've seeded it everywhere. So you want a nice plane of excision, and I think a mini stenotomy would give you that. You wouldn't have to sweat about it. And of course, the vascular complications are minimized. There's no blind dissection as such at the bottom end. So we get thoracics to do it for us, and they're always obliging.
Yeah. Anybody do anything different, Enyi or Ian? Do you do your own stenotomies now, or you get your thoracic colleagues? I mean, I'm a great believer in sharing the responsibility, sharing the experience, and having fun rather than sometimes it's not so much fun, because obviously these cases are difficult. But it's just sharing that responsibility. And if you have to put, if you puncture the pleura, which is probably quite likely, then they put a chest drain, and there's no sweat for them. But anyway, anyone does anything differently?
Ricard, at St. George's, we're very, very fortunate. We operate next door to our thoracic surgeon colleagues, so it's not a problem. In fact, it emboldens us to take on retrosternal goiters that a lot of people would probably shy away from, because we know that they're next door if we need them. You didn't. I can't remember if you mentioned what his pre-op, his laryngoscopy was. Did he have a
I was just trying to kind of divert the discussion to a specific focus, and then I'm going to move to the to the next one, which is that specific one. So yeah.
can I just say, sorry, Enyi, for the scan we've got here, this looks like an arms up scan, presumably to look at the chest, but an arms down scan can be quite useful to look at your surgical anatomy when you're looking at how far. I mean, we know that the arms up are going to force it lower down into the chest, but having it with the arms down gives you that bit more of an idea. It may not make any difference in this case, but when you've got a degree of retrosternal extension, that can help you work out what might need to come out through the neck.
Yeah, that's great. Thank you. Great comment.
No,
So the question is now here. Sorry, and you want to say something?
Yeah, no. The reason why I asked about the preoperative laryngoscopy, because if he had if he has vocal cord palsy in the context of a suspicious nodule with a type 5 cytology, then that would make you even more concerned that this is an infiltrative lesion, and getting it out from the superior mediastinum is not going to be easy. And then one final point on those scans is that sometimes when you're doing a sternotomy for access, if it's something you do infrequently and you may be doing it with a thoracic colleagues who don't do it very often, you sometimes do actually have to remind them that opening the pleura to help push the goiter up is a necessary step. They won't necessarily do that for you. You actually need to tell them to do that. So it is something to, I think it's just more to understand that just because you have a sternotomy doesn't necessarily give you the access that you think you're going to get.
You're absolutely right, and I think that's a very good point. And I think again, that kind of brings the point that is actually very, very useful to have somebody you work all the time, and we do have. We got a kind of a team of about 8 thoracic surgeons now at the department or in our hospital, and there's only 2 that basically just help us to do this, and we do that all the time. So they're almost part of their job plan that they will get involved with us. So just before we go into the issue about the nerve, I would like to kind of basically ask you guys. Where in general, where do you normally start? If you have somebody like this with a big unilateral mass and very little on the other side, would you start on the easy side or the pathological side? Can I have some views? Ian, you obviously I cannot see you because you are in the audience or in there. But Ian, where do you start?
It's been my practice to start on the pathological side.
And then the question is that if you get stuck and you think, God, this is not going anywhere, what do you do? Do you persevere with that, or you flip to the other side and then get out of the way before you get into a kind of major sweat?
It's never happened to me yet that I've had an open and shut thyroid. And I think if that were the case, I wouldn't go to the other side. We haven't talked about the other side in this, whether it looks malignant or not. And the assumption that the other side you're just doing to give RAI, I think if you got stuck, RAI is not going to work anyway, so there's no great need. But I suspect what you're going to say, what happens if you hit the nerve, given particularly the last point in the slide. And in practice, I think if I had a nerve injury, which is going to be likely in this situation, then I would stop and get pathology. Because if that came back anaplastic, I would say, well, there's no virtue in giving RAI, so I'm glad I stopped. But I would be going into this with the plan of a total thyroidectomy in this setting.
Yeah. So the fibroptic laryngoscopy on this guy was essentially kind of normal. There perhaps a little bit of kind of reduced mobility, but really nothing else. His main present complaint was that he was short of breath, and that's basically what happened. And then when we went to see the to get into that chest, obviously we did a full sternotomy on this guy, and then we saw that there was a really large segment of nerve going through that mass, and then there was absolutely no way we could not resect that nerve. And can I ask you, what would you do in this situation? Do you resect the nerve? You try to preserve. You try to kind of get into that malignant mass, and then start kind of peeling, 380 degree the mass and leaving something in the nerve. What do you guys do? Farouk, can I ask you in the first place?
So, I mean, my personal practice is to do different to what Ian just said. I'd start with the non-pathological side to ensure that one vocal cord is preserved. So we had this very recently. So start off on the smaller side. Number one, it gives you more space, more access. on one side, and it ensures that at least one vocal cord's patent. The likelihood of injury on the right-hand side, even if it's a temporary neuropraxia from traction, is actually quite high. And sometimes it's unpredictable. You might stimulate the distal recurrent laryngeal nerve, but when you do it at the main trunk of the vagus, you're not going to get any signal, and that could be neuropraxia as the nerve turns around. So I'd start with the smaller side, the side that's completely in the neck, and then proceed. But if it's an entwined nerve with the vocal cords, unlike parotids, I would resect it, because there are various different approaches to laryngeal and vocal cord augmentation, which have limited morbidity with one-sided injuries and can be corrected. But yes, I mean, look, if you've got a nice segment of trunk, you can do an answer to recurrent repair and microanastomosis, and you might get some degree of return of tone. You won't get an arytenoid that hoods down, but ultimately most of those patients need some form of injection augmentation anyway.
Okay, that's great. That's a very good point. Anybody would do anything different? I mean, I do find that sometimes if you get three to stock, or it's going to be really too difficult. I think as Farouk said, they're going on the other side and using that easy side, to start with, and then getting that potential kind of tracheostomy kind of out of the way. It is actually very useful. Neil, you've got your hand up.
Yeah, just for the going which side to start with, I guess a bit of a combination of Farouk and Ian, really. So if there's a preoperative nerve palsy, then in a way it's easy, that's coming out. If I've got a tumor like this where I'm worried about losing the nerve at some point during the operation, I think the benefit of starting with the normal side is, I mean, we're all expecting, all experienced surgeons, we should be able to take a straightforward lobe out without a problem. But if there is a problem with that normal side, you've then got that little bit longer for it to recover. We're worried about the pathological side nerve, but you want the good side, taking that out. Then if there is a bit of tension on it, if there's a bit of neuropraxia, you don't know how stuck down the whole thyroid will be. We know that for certainly advanced malignancies, there's a lot of tissue reaction within the neck, and the tissue planes aren't as easy to follow. For the actual nerve involvement itself, I think it depends a little bit on what you're seeing when you look at the nerve. From the sounds of it, this one was buried deep within the tumor. If it's just invaded a small amount, you might be able to peel that off. But when you've got it going through the main body of the tumor, I agree with Ian and Farouk, and I'd resect that nerve.
Yeah, and you've got a hand up.
Yeah, thanks, Ricard. A couple of things in terms of which side to start. I'm not sure there's much added value starting on the non-cancer side in terms of giving you additional space, because you can see, if you're talking about this particular case, you've got a large mass on the ipsilateral side, and moving over to try and remove a much smaller thyroid on the contralateral side, I don't think is necessarily going to improve your access. So I would always start on the pathological side. I'm using more continuous intraoperative nerve monitoring now. So I find that it achieves two purposes. Number one, at the very beginning, once I've made my skin incision, I can actually access the carotid sheath, within a few minutes, and place the probe over the vagus. So that actually tells you the integrity of the nerve from the very beginning, before you've even started to do any exposure of the thyroid. So if the nerve is working on that side, then that tells me, well, if it's possible, I would like to preserve it, because we know that resecting the nerve doesn't necessarily improve overall survival. However, when you do get to where the nerve is running into tumor, and you find that it's more or less, encased by tumor, then you have to make an executive decision at that stage that trying to shave it off is essentially going to be futile. And in that situation, I would be resecting it and looking at doing some form of intraoperative nerve repair.
Yeah, no, that's a very good point. I was going to basically ask the issue about the nerve monitoring. I know you guys from that you all use nerve monitoring, but I again recently kind of gradually shifted into the continuous monitoring. I think that's, for this sort of kind of case, it's just it's not, I think it's very useful, and I think you have the access. There's no problem in terms of kind of getting the monitor in the vagus. So can I ask kind of the panel, who use intermittent monitoring and who use continuous monitoring? For this case, what would you do? I mean, I did this case. I did it about kind of 8 years ago, and it was an intermittent neural monitoring. But now I would probably certainly do a continuous monitoring here. Can I ask Ian?
We do actually have access to both, but have hardly used continuous. I don't think it's clear what the right indications for it are. We have used it when we've re-explored bilateral central necks in cases that we think are going to be difficult, and I think this is going to be difficult. So I think that would be reasonable. But we 99.9% of the time use intermittent in Edinburgh.
Yep, and Enyi, you already said. Farouk?
We use intermittent, but we do both the distal and the vagus.
Yeah, and Neil?
Yeah, I mainly use intermittent, but I'm moving more towards using continuous recently, and I think once I'm up and using it fully, I would use it for this sort of case.
Yeah, absolutely. I think we all I think we all kind of shifting for that sort of kind of thing for the difficult case. I think we all agree that nerve monitoring is probably really an essential part of the of your thyroid surgery these days. But I think for this kind of difficult case, I think a continuous monitoring has something to add. Enyi?
Just quickly on continuous versus intermittent monitoring. I initially dabbled in continuous monitoring about 8 years ago and quickly abandoned it because I thought it was a bit of a faff and not useful. but I have to admit it is now part of my routine practice, because when you do need it, there is a learning curve, and you both in terms of ease of application of your probe on the vagus, and understanding why when you're not doing anything, the machine is beeping at you and giving you all kinds of noises that will just frustrate you. So you don't want to be using continuous monitoring for your first difficult case where it will be useful. You really need to make it part of your routine practice. I just wanted to sort of make that point.
That's a very good point. And then with Ian and yourself, we did wrote a chapter in a neurophysiology or book in which we said that at least you should do a V1 in the first place anyway, which I think is actually quite useful because sometimes you start and then perhaps you lost track, and then by the time you get into the nerve, it's too late, and then if that doesn't stimulate, you don't really know whether the nerve was intact in the first place or not. So here, what we found is that you have a kind of very large portion of involvement, and then obviously the question is whether to resect to preserve. Here we decided to resect, and then we did an intraoperative repair. So is anybody would do anything different here? Neil, we had this discussion at BACO, this year. It was interesting, I think, session. What would you do?
Yeah, I agree with you, Ricard. I think that this nerve would need to be resected. And again, I'm a bit pedantic about the correct use of here, I would say, is resection as opposed to sacrifice. People talk about sacrificing nerves. This is an oncological resection, as part of your cancer operation. So it's a resection of the nerve. And yes, repair, microsurgical repair of the nerve, I think, is better, as Farouk said. If you can just get a bit of tone, stop the retinoid from dropping down a bit, maybe. Functionally, that will help them regardless of what you then need to do in augmentation.
Yeah, great. So we did this narrative review for the laryngoscope, where Ian was part of that group, and there was not a huge amount of evidence. The majority of the evidence is kind of the Far East, sort of mainly from Japan and China, very little from Europe. But it looks like I think the consensus is that everybody kind of shifting to if they can do a intraoperative repair. And I think Farouk has already highlighted that, and I think it will not recover the function, that's for sure. There's no two questions about that. But the bottom line is that that nerve will probably keep the tone, very likely will keep the tone, not necessarily all the time. It will the vocal cord will be in the same level. It's not going to basically become atrophic, and therefore the originoid will not prolapse. So in a way, you will keep a very decent kind of larynx, if you like, structurally, and therefore you will be able to then, if you need to, then augment. That's fine, but quite a lot of the time you don't need to, and I think that's very good. But the evidence is quite anecdotal still, and I hope that this type of panel will hopefully instigate some further prospective studies, and that's basically what we did. I mean, obviously you got some options here. As you can see, we use the answer. The most important thing is not to have any tension. Make sure that you, in a local invasive thyroid cancer, there's a value, especially in a poorly differentiated setting, if you have, is just to take a little frozen section of the nerve to make sure that you don't kind of stitch your sutures into tumor, and then use either 8 or 9 prolin, and you only need 2 or 3 sutures at the most, and then you can put a little bit of Tessil on top, and that will help. You need to then involve obviously your speech and language therapies right in the beginning, and then you move forward. So this is basically the specimen, and this is the chap at 3 months.
Last night I went back to work. I've been driving for 2 weeks. I had no problems getting in and out of the cab. My normal day-to-day working has been fine as well. Felt a little bit tired at first after going back to work after sort of like three months off, but gradually getting there.
Good.
Ricard,
So,
which side did you start on?
You can talk now if you want to.
Sorry, I'll just get. Sorry, yes.
Which side did you start on?
on the pathological side.
Good man.
Yes. Sometimes what I do, which is actually quite but I think you had some cases, in which then you probably kind of shift to the other side. And the other thing is that sometimes at the beginning of your day, this is going to be, it's not going to be a case you're going to do at the end of the list, isn't it? It's something that is going to be in the morning. You're probably more fresh in the morning. And I think there's a very good value of what Neil said about the fact that you're probably more fresh. You get that out of the way, and then you think about it, and you worry about the big the big site. Also, sometimes what I do for these big cases, in order to get some space, if I feel there is a kind of a problem, is to do a 2 lobectomies rather than a total thyroidectomy, because then the other side is just not on the way to kind of manipulate. So I just get one out of the way, and then the other one is kind of easy to do. So I just want to involve Professor Reed on some of these discussions. So I'm going to go into the histology and what we do next, and this is was called a conventional T4N1B because we had pathological lymph nodes in level 7, and then obviously they couldn't really tell you because we have to shave everything from the big mediastinal structures, whether that was an R0 or an R1. Obviously, we clinically we felt, or surgically we felt it was an R0, but obviously it was quite close. It was at the edge of the tumor, and then that's why they gave us a kind of an R1, and it's widely follicular bearing papillary thyroid carcinoma. So what I'm going to ask Professor Reed is that whether you would in this kind of setting, obviously you probably want to use a iodine ablation. Which dose would you use, and whether in this sort of kind of R1 nasty unpleasant tumors, whether there's a consideration for post-op radiotherapy?
Thank you. I think you said this case took place 8 years ago, so I suspect 8 years ago that the decision would have been absolutely straightforward, and that would be I would give 3.7 gigabecquerels of radioiodine with thyrogen stimulation. I think even today, given what we've seen there, I would still give the same dose of 3.7 rather than the lower dose. With regard to the role of external beam radiotherapy, I mean, I've been treating thyroid cancer for well over 30 years now. I think it was in 1987 I took over the practice from Thurston Bruin. And I think I could probably count on one hand the number of times that I have used a combination of radioiodine and external beam up front. I got my fingers very badly burnt years and years ago, and I vowed I would never do it again unless there were exceptional circumstances. There was a guy actually who had a very big tumor and not dissimilar to what you're describing here, and we gave him radioiodine and external beam, and he finished up. His quality of life was miserable. He had fistulae and all sorts of problems. So I personally, I know, but the Germans in the past have published extensively, I think indicating that they often do combine, but I think my impression is that in the UK, there are very few people who would use external beam at this point. Whether at a later date, if he relapsed, then there's a completely different discussion.
Yeah, I agree. I mean, I think we didn't use radioiodine. Sorry, we didn't use external beam here. We used radioiodine in the past. Right at the beginning of when I started consultant in the turn of the century, we used post-operative radiotherapy in some cases, not dissimilar to these ones. And you're quite right. They were absolute disaster. We did once a 26-year-old who had a very unpleasant advanced disease, and he ended up having a second primary in the hypopharynx, and that's was even more unpleasant. So I totally agree with that. Now, in terms of if this was instead of a conventional widely follicular variant of papillary, if that was polydifferentiated, and more the pathologists they call these percentages of polydifferentiated, would you do anything different? Let's say 80% polydifferentiated proportion. Would you change the dose of radioiodine? Would you do anything different?
I don't think I would. No, I think given that the story here, you've done a great job. You've done a really good job surgically. You want to make sure this guy is going to have the best chance of living, and I think to compromise on the dose, I think, will be taking an unnecessary risk.
Yeah,
but there may be others who would give 1.1, but I personally wouldn't.
Yeah. Anybody does anything differently from what the discussions that you have in the MDT for this, Farouk, perhaps a slightly different practice in Sydney?
No, I think the thresholds for radioactive iodine are very low. So I completely concur with what you've done.
Yeah.
Use them for even small cancers.
Yeah. Great. So I've got about 4 cases. I prepared 4 cases, and I think quite some of them are actually relatively straightforward in a sense that probably it does not. But I've got the last one. I think it will probably generate quite a lot of discussion, and that's actually something that we did present at the World Thyroid Congress. And I just want to kind of probably share that with you, and I think that's going to be a really good combination of surgical and I think non-surgical therapy discussion. So this was someone who presented a typical story just before Christmas in 2022. She is a 39-year-old. She worked as a support officer, a prison officer. She had a lot of kind of problems because she saw somebody being murdered in the prison there where she was working, and she became very stressed. So she had post-traumatic stress disorder, and she became very afraid of seeing the doctor. So she had a very large goiter when she presented. She's you can see the picture, but apparently she had this thyroid lump basically from the age of 5. Whether that's actually, believe it or not, there's always been something there. But over the past 12 months, and that was coinciding with the fact that she had been witnessed this very unpleasant event, she had a kind of a gradual rapid increase, which is obviously very worrying. And then she was seen at one of the network hospitals. She has an ultrasound FNA in the first place, and then they couldn't really call whether that was an anaplastic thyroid cancer or medullary thyroid cancer, but certainly very atypical spindle cells, really, really very unpleasant type of cytology. But she had a normal calcitonin and CA. But her performance state is actually very good. She plays walking football for a local team for Crystal Palace girls. So she was relatively fit, and but you can see that this very unpleasant sort of kind of a tumor. So she had a very, very large grade 3 goiter, if you like, and then and you can see that the left vocal cord it was completely squashed. That's a picture of the fiber optic laryngoscopy. You can see the kind of the vocal cord here. everything is really, really distorted, and we couldn't really tell whether that was impaired because of the kind of the sheer bulk and pressure of this, or there was true infiltration. So I had extremely bad laryngeal distortion, arytenoid edema, and she had palpable lymph nodes. And then when we did the systemic imaging, she had metastasis in lungs and ribs. So a really very bad really situation here. This is an example of our CT scan. Again, we did that with contrast, and obviously that's really extremely important to, if you want to kind of really operate on this patient. And it highlights the fact that she already had M1 disease, which is a really bad prognostic factor. Now then, we had obviously a lot of discussion about this patient. We didn't do kind of BRAF in the upfront, and it also progressed quite rapidly. It didn't progress in a kind of in a wild, fiery way. So and when you felt this, you could mobilize it. It felt that although it was very big, it could be moved from the deeper structure. So here we got something that is actually poorly differentiated, potentially kind of partly anaplastic. You couldn't really tell from the core. Is anybody who would do anything different here in terms of kind of further investigations? She had a PET and everything else. So it is, the PET did not really show anything different from what she had in the cross-sectional imaging. What I'm asking you, and I think I'm probably going to ask with Ian, is that whether in this setting, if you think that obviously this girl is developing an anaplastic, which is obviously the concern, is whether you would start kind of doing BRAF and see whether you can do anything neoadjuvant here.
It's a difficult case, isn't it?
Yes, it is.
Obviously, you operated, but yeah, I think we probably would. We don't do molecular testing in many tumors, or we don't ask for it. Pathology sometimes do it, but I don't know what it means very much. But my understanding is if there's BRAF mutation in anaplastic, then there's a targetable systemic treatment. And we would probably do it for that at the get-go. We can get it back very quickly. And if it's growing so fast, you can't wait for a BRAF, I think she's toast anyway. It's partly, I'd be interested in the volume of distant disease, because if that was very large volume and rapidly progressive, then I would be cautious about doing anything in the neck. But assuming it's not, and it's not growing that fast, then you got to control her airway, because she's going to lose her airway, and she's not even 40 yet. And so that's
exactly the philosophy that we had, and the justification that I gave to the MDT, because there was a lot of kind of debate on that as to what how we proceed. So based on that, is there anything Farouk, for instance, you or Neil, do you have any? Would you do anything different in Birmingham or Sydney in terms of kind of doing perhaps BRAF up front to see if any neoadjuvant treatment could be considered here? Farouk?
Yeah, I mean, potentially, like I agree with Ian, if it's that fast, but yeah, BRAF on the cores are available for us. We also have a kit from the US, which is 16 genetic markers that's being marketed. It's not that widely used. There are 16 prognostic markers. I'm not sure what all of them are, but in these particular cases, they're probably useful. But BRAF is available. We would do it on the core. And yes, that would provide us some target for, I mean, regardless of what you do for this lady, you're offering surgical palliation. She's incurable. I think the treatment intent is local control and palliation.
Yeah, I agree, and that was the philosophy. But my concern was that she ended up with potentially a tracheostomy, and it was just in the work come up to Christmas, and then that would have been an absolute disaster. So Neil, do you have any comments on that?
Yeah, it would be lovely to get BRAF on all of these. Ian's talked a lot and shown us about good pathways for rapid anaplastic diagnosis and early onset molecular testing, which is what we're implementing in Birmingham, so that when we get patients where there's a query of anaplastic, it sort of triggers the pathway where we can get mutation results, certainly BRAF, but looking at RAS and the others quite quickly. I agree her airways is the biggest concern here. It's either so rapidly growing that you just need to look at immediate palliation, or you've got some time. If you're going to take it out, I mean, we caught a glimpse of your next slide. It doesn't sound as though you've taken out her larynx, which would be fairly exceptional for palliation. Although if it is a differentiated thyroid cancer, even if poorly differentiated, then I don't think that should be withheld from the table or the discussion table, just in the presence of some metastases distantly. So it would depend a bit on that side of things, how confident you are in your imaging. But I think there's a query of anaplastic, getting the markers first, if the time allows, is good. But and a core biopsy, you mentioned core, Ricard, is key. If it's only been an FNA, you need to be getting a core biopsy in these, so you can be looked at properly.
Yeah. And would you add anything?
Well, we've got a very close working relationship with the Royal Marsden, as you know. They're part of our MDT at St George's, and Kate, I think, who's going to be talking to us later on, systemic therapy for these advanced thyroid cancers, has got experience. We do have access to molecular testing. I don't think we utilize it as much as we should. I think it's part of the national. It's on the national sort of testing registry. You can get BRAF testing.
Yep.
And RET as well. So I know our American colleagues in MD Anderson in particular have been they've done a lot of work looking at neoadjuvant treatment and then going on to operate. And that's something we've kind of entertained the idea of doing, but thankfully these cases are quite infrequent. So we've not really progressed that, but we would look to get molecular testing.
No, absolutely. So we have now developing a rapid BRAF turnaround testing. We should really have that within 72 hours. I mean, this case did fall into kind of, she was not that compromised, but was clearly and we didn't really have a kind of a reference point. So what I did, obviously, I did try to kind of counsel her as best as possible, and then what I tend to kind of do is I explain half of the facts in one, but I would like to kind of then see them the following week, and partly that just to kind of for them to kind of assimilate the rest of the story, but at the same and the management plan, but at the same, and also had the opportunity for the MDT to have that discussion, but also to see if there's actually any immediate progression, and obviously have everything in place that if the airway deteriorates at any point in time, she could come straight away. There is a potential kind of value on these patients to get admitted and get everything kind of done while they are admitted. But because she had a very supportive family, she's got post-traumatic stress disorder, we decided not to kind of have her in the hospital too long. So Nick, can I ask you, in terms of kind of what would you kind of have? We did operate, as you can see, and I'll show you what we found. But in terms of kind of potential kind of neoadjuvant therapy on this sort of kind of cases, do we have anything available for BRAF positive and BRAF negative, which is the main kind of potential molecular marker here?
I was going to make some comments, if I may, if I comment on the molecular
profiling.
Of course. We do now have the national directory in Scotland which allows us to. It's really only just been approved very recently, so we're now able to get a panel of BRAF, TERT, RAS, NTRK, and RET. We also have recently been negotiating in the west of Scotland to try and get a rapid turnaround on the BRAF mutation, because whilst we're quite happy to accept a 14-day turnaround time for other thyroid cancers, with these anaplastic tumors, we clearly need a fast turnaround. And in fact, it turns out that we are getting twice weekly testing. So they'll do a run on Monday and another run on a Thursday, which means actually you should get it 4 working days later. And this is very important. If the tumor has a BRAF mutation, then the drugs aren't licensed, but dabrafenib and trametinib have been available. Novartis had been giving them on an expanded access program, compassionate use. I believe in England that from what I read about my colleagues in the Thyroid Forum, that they're able to get it on an individual patient request basis. And similarly in Scotland, certainly in the west of Scotland, we have been able to get dabrafenib and trametinib, and there have been some quite remarkable responses. Although one caveat, and as a patient of mine at the moment, well, I was off sick 3 weeks ago, and the patient had a great initial response, and then I won't say what, but somebody stopped the drug because she was mildly hypertensive, and in the 10 days she was off the dabrafenib and trametinib, the tumor has blown back. And I've been trying to make the point to them that I don't care about hypertension. She's going to be dead within a few weeks if you stop it. But the alternatives then, conventional chemotherapy, carboplatin and paclitaxel, there's been some benefit. And you sometimes see patients who have a transient response. And just as when they've had 3 or 4 cycles, and I would then sort of go to Omar and say, Omar, look, this patient's having a response. And then 3 weeks later, by the time he sees them, they start growing again. So I've been very disappointed in the long-term results from carboplatin and paclitaxel. For the BRAF negative patients, it's worth thinking about lenvatinib. And then the ATLEP study, which was presented at ESMO last year, and there is, in fact, a published paper with a smaller number, has again shown quite that. So that's a combination of lenvatinib and pembrolizumab, a checkpoint inhibitor. And that has shown a number of patients still alive at 2 years. And obviously, historically, anybody with an anaplastic thyroid cancer who managed to make it to 12 months, you would normally go back and check the pathology. So there are some options. We're going to touch upon this in the next talks, but the use of these SACT, these tyrosine kinase inhibitors up front does sometimes give you an opportunity to get some tumor shrinkage, and also just to sort of see how well it shrinks. And it may be there are opportunities for delayed primary surgery, but clearly in this case, you've done your surgery up front, and therefore you would want to give something systemic afterwards.
Yeah. So yeah, I mean that's exactly what we did. So I don't think anybody potentially can argue with the extent of the dissection. As a matter of fact, it was actually amazingly very well encapsulated, and everything kind of came out. To the fact that we had kind of essentially kind of an R0 kind of resection. We did take the sternocleidomastoid on the ipsilateral side, but we managed to preserve the both nerves. She's had a kind of basically normal vocal cord function, and I managed to preserve a parathyroid on the other side, which means that she's got a kind of reasonable. She doesn't take any calcium supplementation, which is actually really good. Here I did start on the pathological side, and I did consent her for a tracheostomy. I didn't consent to her for a laryngectomy because she did refuse to that. But I just kind of had a feeling, because the way that this was moving, and sometimes just going back to the to the old-fashioned clinical examination, and the fact you see the patient yourself, the disease tell you something, and if it'd been completely stuck and it was not kind of rocking, then I would have said, okay, probably that's not the thing to do. But anyway, that's what we did. And
Ricard, why did you take out the other side if it's anaplastic?
Well, because initially we were not 100% what we was. It was very anaplasticoid, but not fully anaplastic. And so here, as you can see, the histology it was 70% anaplastic and 30% kind of well differentiated. So it had obviously multiple foci vascular invasion. The whole thing was just really horrible. She had 84 lymph nodes, so a good 6 out of 84 lymph nodes, so a very good lymphoid ratio. And technically speaking, it was actually R0, which is actually really good. So in terms of the airway, she had absolutely no problem at all. And I think my rationale to go to the other side, basically based on that, is also to make sure that that's also out of the way. And because the first nerve was okay, and I just went to the second side and I did the nerve, and also I needed to basically remove some of those lymph nodes on the other side too. So this is the pathological specimen. Now, what we did here is that we did the BRAF, and also we did PDL1. So the BRAF was negative, which was really disappointing, but then the PDL was positive. So we thought perhaps we could give her some immunotherapy at some point. And that's basically now that's where we are, or how we did it. And she's fine. She's had some disease, some degree of disease progression. So the paclitaxel and the carboplatin has managed to kind of put things on hold. And now we put a request for lenvatinib and perhaps pembro. So the oncologists are doing that. But the problem with this girl is that after we presented this case in the World Thyroid Cancer meeting, and it was the last case of the last panel, so we didn't really have a lot of time for discussion. But having discussed that with Ian McIver, said, well, unless you give a regular treatment, this girl is going to die. As soon as you stop the treatment, everything is going to go wild. And it's probably what Professor Reed said already, that you don't continue to treat her, she'll be fine. So at the moment, what we have is that she's completing or she's just about to complete the last cycle, and then we've applied for compassionate lenvatinib and pembro. So Neil, you got a comment, and then I can ask the rest of the panel. We got perhaps 2 minutes to wrap up the panel.
Just be quick then. That thyroglobulin is interesting. So are you presuming the residual disease is papillary thyroid cancer rather than anaplastic?
Yes. There
was
a question.
That makes a huge difference.
Yeah, there was a question as to whether we at some point we could have actually given some ray-iodine, but because of kind of the disease progression in the lung, we decided not to. But there was a discussion about that, and perhaps Professor Reed could add something on that.
I'm not sure about that. I was going to ask you, was her TSH high before? Was her initial TSH elevated? Because if she had a multinodular goiter since she was 5, had this transformed and had to become hypothyroid, and therefore TSH was driving this and making it grow in the year before. But as would I give iodine now? I don't think so. I think I would just try and get lenvatinib. And I've got some patients who've been on one particular patient who's been on lenvatinib over 10 years. He actually started at the Marsden with Kate, and then moved up to the Isle of Lewis, and I took him over. And I think he's been on it about 12 or 13 years, and he tolerates it extraordinarily well.
Yes, I mean that's basically what we have. That's what we've applied for. So I think it's 10 past 3, and I think we do have no more time to discuss on the occasion. I think hopefully we managed to incorporate all the kind of different aspects of local advanced disease to a point. I really thank the panel because they've been absolutely fantastic. I think there's a breadth of knowledge, and it's really nice to have Professor Reed on board to give us the non-surgical wisdom. And I think it's been a great pleasure from certainly from me, and I'm sure that from all the panel that they participated in this roundtable. So thank you very much, Jay, and we'll stay for the rest of the conference. And Farouk, have a good party. Now that it's 12 o'clock, now you can go partying in Sydney.
Thank you very much indeed. That's absolutely a great panel.
Thanks, Jay. Thank you.
Thank you very much, guys.
Thank you.
Thanks, everyone. To the time. Thank you. We'll have a 20 minutes break, coffee break. Then we'll be back.
Thank you.
Brilliant. And Ian, would you mind just answer this from here on type? You can type it. Yeah,
I'm still online. I'm not going to disappear. It's been very good.
So you can. You want this? Okay.
Sorry, and is there anything else or any questions from the audience, perhaps?
There are some questions on the chat, but I'm just going to answering them in my biased way.
of course.
Mainly anti-Spanish kind of rhetoric.
So yeah, you started on the right side, obviously.
No, I'll do that. That was good. Thanks, Ricard.
That's brilliant.
I feel like I
really,
operated on that guy the first case. I've seen that case so many bloody times now.
I know. I'm sorry.
It's good.
I'll change. I've got some more. I got some more, so I'll change it. But it's just it provides good discussion.
No, it's good. Isn't it?
Thanks, Ricard. And
Thanks,
Ian,
Thank you, guys. A really good discussion. So
great fun.
yeah, that's
I'll
brilliant.
hang around, but I'm going to go and have a break.
I'm going to have a coffee as well. I mean, it's 20-minute break,
Cool.
so I'll have a coffee.
Thanks, Jay.
Good to see you, Neil. Cheers.
Thank you, guys.
Thank you.
Thank you.